I basically, my kind of like background about me, I grew up in New Jersey, South Jersey specifically, right outside of Philly, and grew up playing basketball, and just had general interest for science, and kind of decided early on in my career, like in high school, that I wanted to go to medical school. So when I was evaluating kind of like where to go to school, I looked at traditional undergrad options in my area and just kind of a little farther out. And then I ultimately found out about like accelerated medical programs for those who already know from high school that they want to pursue medicine at an early age. So I looked up 7 and 8 year programs. That's something I'm not sure if like people who are early on are still eligible to apply to, but they have accelerated programs. Like for example, I did a 7-year program where I got early admittance to medical school as a high school. So I had the standing already. So I basically was accepted both to undergrad and medical school simultaneously, contingent on the fact that I kept up a GPA that was predetermined that I signed a contract for, as well as did well in the interview and got a certain MCAT score that they wanted that was going to be determined 3 years down the line. So that's how I basically got into medical school. I, decided early on that this was for me. And then I did 3 years of undergrad, taking my MCAT in my second year. And then did my third year, was kind of like my senior year of undergrad, and then went straight into medical school. When everyone else, my peers, were going into fourth year of college, I was starting medical school, and then went through medical school, went to medical school and undergrad at Nova Southeastern in Fort Lauderdale. So I made the move from New Jersey to Fort Lauderdale, loved it. Was deciding kind of what I wanted to do long term. I went into medical school thinking emergency medicine, and after shadowing in emergency medicine, I was like, I don't know if this is for me. And then just had a really good experience with my family medicine rotation and the doctors in there. I'm also a certified personal trainer outside of this. So during medical school, I was really into fitness, like working out all the time, and a huge push on preventative health. I spent a lot of my rotations wondering how these people ended up in like the situations they did. And I felt like a lot of it was like lack of education prior to, and I thought family medicine would give me the best opportunities to kind of, at least take my time and see patients, consult them on diet, exercise, and just more preventative type things. And I really have an interest in sports and fitness and things like that. So I ultimately chose family medicine in order to do, as well as sports medicine fellowship afterwards. So family medicine is a 3-year program. A lot of people ask what the difference between family medicine and internal medicine is. I know we have like a large audience, so everyone's obviously at a different level right now. So one of the major differences is family medicine. Your scope of practice is much larger than internal medicine. Internal medicine deals with strictly adults 18 and up, but in family medicine, you get training that you're able to deal with obstetrics and gynecology, as well as pediatric patients and as well as your adult patients. In a broad sense, family medicine is more focused on outpatient medicine, while internal medicine is more inpatient medicine. Inpatient and internal medicine physicians work in the hospital, can work outpatient as well, often pursue specialties such as like cardiology, GI. Family medicine also is outpatient. It has other fellowships. They do adolescent medicine, sleep medicine. You can do palliative, geriatrics. Like I'm planning on doing sports medicine. So that's a good range. And you see a different patient population. You're everyone's sole, so you're some people's sole providers who can't afford to go see, a dermatologist, go see a GI. So with family medicine training, you're getting, a large scope, and you're doing as much or as little as you can. If you're procedure heavy, you can learn in your residency how to do all these procedures, skin biopsies, central lines, different things like that. If you're not so into those, you can just strictly do like more outpatient medicine, refer out for procedures and different things. So it all depends on what you want to do. So that's kind of a background about me, and then we'll go right into this case. So my name is Ravind Patel, Dio, and then I'm Vinny Patel on IG. If you guys want to follow me, I know a lot of you have already. So let me move on. All right, there we go. So you're in the hospital, and then you're the resident there, and let's say this happened to me before. So you get a 68-year-old male presenting to the emergency department via EMS after a seizure at home. So already, you're already thinking, you want to think big picture, right? So a lot of the times people narrow in on what this could be, but you want to keep a open mind. So 68-year-old male, okay, so you're thinking older man presenting to the emergency department. His wife or whoever was there was unable to drive him. I guess they called 911, had some sort of seizure. What kind of seizure was it? We don't know, but basically presented to the ED like this. So you go into the room, and the patient's wife's there, and she tells you, my husband woke up at 6 o'clock in the morning to go to the bathroom. He started to feel lightheaded. When I saw him, he looked pale, and he told me he was having trouble hearing my voice. Then he fell and had a seizure. Okay, so you have the historian there. The patient is kind of he's in and out. He's waking up, but he's like, oh, can you just talk to my wife? She kind of knows the whole story. So she said he had a seizure. So we're going with that right now. Okay, so what questions would you guys want to ask about this current situation already, just from hearing this? So I'll let you guys type in the comments for a little bit, and then we'll kind of read some of the answers. So if you had a patient who the wife is telling you, oh, he had a seizure this morning, and now you're here, it's like maybe 7 a.m., you're finally seeing the patient, what kind of questions would you ask? There's no wrong answers. You guys can just shout out whatever or type in whatever. So yeah, that's a good question. I see. Has this ever happened before? That's always a great question, because a lot of times that can save you a lot of worry, because a lot of times you see people coming to the ER and then it may be their first time, maybe they're 40, the first time having any heart issues, but some people who are older, they'll be like, no, this is my third time it happens. Like, this happens all the time. This is what they do. I'm trying to see this person, but I didn't get in. And you can get more of a history that way. People are saying medical history. That's always very important, because you want to put the patient in context. If this is a 68-year-old who's biking every day, super active, no medical history, we're concerned. If they have, diabetes, hypertension, hyperlipidemia, you're thinking different things. So it's always good to get a proper medical history. Some other people are saying family history. Family history is huge. You can always ask. I feel like people forget to ask this a lot. And I feel like it's very important to ask. We just had a patient last week where we, family history, she came in with shortness of breath. We asked family history. She didn't really say much. She was like, oh, my dad passed away. And then, when I asked her again, I'm like, oh, what did your dad pass away of? He died of a blood clot. And then, what do you know? We did a further workup, and she also had a blood clot. So it's very important to ask family history. Sometimes it's a little uncomfortable to ask in the beginning when you're new, if you're a med student or if you're shadowing. But, you just have to ask, even if they say, oh, my parents passed away, just if you're comfortable and the situation calls for it, knowing why and what medical history they have can definitely help you out. Is he taking any medications? That's important to know. Is this the first time to occur? Did he hit his head? All very good, important questions. So there's something in med school you learn that we still use. As you get further out in training, you don't necessarily write all this down and look through it, but it's good exercise when you're in medical school, even when you're shadowing, to kind of look at how you're going to ask some of these questions. So old CARTS is a mnemonic, and it's onset, location, duration, character, alleviating, aggravating, associated, radiating, timing, and severity. So initially onset, you want to find out when it happened. Was he complaining since 11 p.m. last night that he's been feeling like this, and then finally at 6 a.m. he had the seizure? Location, this can be, I think of it in two ways. Where did it happen? Was he out at a mall? Were you guys at breakfast? But no, it happened in the bedroom. Also, location is, it's hard for this, but when you ask symptoms, you want to know, if someone comes in with chest pain, chest pain is a very vague complaint that we get a lot of the times, and we want to look at location. So sometimes you'll say chest pain and people point at their stomach. So you always say, can you point to where the pain is? And if it's chest pain, sometimes they'll point at their stomach. Then okay, this is abdominal pain. Oh, my arm hurts, and it's the arm's huge. People point to their shoulder. People point to their wrist. So you always want to know location, and then duration. How long did this last? For some people with let's say chest pain, it'll be did it last 10 minutes? Was it only brief, 30 seconds? So in this case, we'd ask this patient, how long were you feeling those symptoms? Right when you woke up, was it 10 minutes after? Was it 10 minutes of you feeling this way? And then how long was this quote unquote seizure? How long was that? How long were you having symptoms? How long did anyone else see you having symptoms? Different things like that. And then character, you want to characterize it. What kind of symptoms were they? You want to characterize the type of pains, because a lot of people will come in and say, oh, I'm having pain. Okay, well, what kind? Is it sharp? Is it dull? Is it aching? And then I think this is one of the most important: alleviating, aggravating, and associated. So you want to see alleviating. What makes it better? Does sitting up in bed make it better? As soon as he had this seizure, was he given a medication? Did he take, I don't know what he would have taken, but did that help him? Did it make it worse? Aggravating? Does sitting up in bed, maybe sometimes when you walk into the ED, they're at an incline, and it's I'm really uncomfortable like this, but you lay them down, they feel better. Sometimes they're flat and you lay them up. Does that make it better? Is it better if I turn the lights off? Is it better with the lights on? Is it better if I talk in a lower voice? So these are different clues that you're helping to narrow in your differential. So you have different problems, problems can be, there's two separate things we'll get into. There's problems and there's differentials. And you want to initially create a problem list, and then through that problem list, you're able to expand upon and make a differential. And then associated symptom is very important. So someone comes in, it's a little harder to apply in our scenario, but it's a really good habit to get into. So you were thorough and you're not missing anything. So associated, if you have someone that comes in with chest pain, you have, you say, what associated symptoms do you have? If you don't ask that, you miss a lot. So, I had a fever last night, I was coughing yesterday, I was having diarrhea, I was having constipation, I'm having numbness. So asking associated symptoms helps put whatever symptom that is into better context. Rating is also important. A lot of MSK complaints, especially even abdominal chest pain complaints, headache, radiating. Where does the pain go? Some people are like, oh, it's localized right here to my epigastric region. Sometimes if there's chest pain, like, oh, it's radiating down my left arm, it radiates up to my neck. It's super important because just asking those questions, and like when you give, because a lot of times you're giving this history to someone else, whether you're the ER attending, giving it to the, patient that you're admitting, to the hospitalist, or you're the med student giving it to the resident. Just going through this in your head and being able to explain it properly helps give whoever you're talking to a better perception of what this is. And they're also simultaneously ruling out things like if it's non-radiating, they're thinking something else. If it's radiating down the arm, wherever it's radiating is important. And then timing also. Was it a thing I didn't really ask until I got into like my third and fourth year of med school was timing, because they would come in and I'd see them and I would just ask questions, but I was like, oh, so when, and you want to put the timing in context. Was it right when you woke up? Like some people say, oh, it happened this morning, and I'm seeing them in the afternoon. Well, it's like, okay, were you up for like 4 hours and you had already went to like your grocery shopping and you came back and you were awake, or it just happened right when you woke up, or like right when you went to bed? So timing is very important. Then severity, having patients quantify it. If you ask them how bad the pain is, they're always going to say it's bad, or, oh, it doesn't hurt that bad. But giving you a quantity is better. So a question I like to ask, on a scale of 1 to 10, 10 being the worst pain you ever felt in your life, and, giving them examples of what the worst pain they've ever felt. And then grading that is very good. So they'll tell you like, hey, it's 8 out of 10 right now. Then maybe give them pain medications, maybe give them fluids, whatever you're doing, the severity could decrease. So you go back 2 hours later and like, oh, you know what, doc, it's a 6 out of 10 now, or it's a 4 out of 10, or, oh, it's 2 out of 10 now, you gave me this medication for my headache, feels a lot better. So having that severity scale helps to kind of quantify it, and you're able to better monitor the patient's progress as you're seeing them, and then even as an outpatient basis, like, I'm having this like 8 out of 10 back pain, and you give them some stretches, some medications and all that, like, what, now it's like a 5 out of 10. And then even quantifying this severity with duration, it's like, or with associated, it's like, it's a 4 out of 10 when I lay down, but when I stand up, it's like a 10 out of 10. So, getting this, the more details you can grab from the history, and that's what kind of the focus of my history, my presentation is. Just grabbing a good history is very, I think people always want to jump to labs, people always want to jump to imaging, but I feel like you get a lot in the history. Like I'm on emergency medicine right now, and just so much of it is like sitting down and just like getting the full history, and then you really get to learn a lot. Like, were you previously hospitalized? A lot of people are like, yeah, I just got out of the hospital. And like, if you don't take time to ask these questions, that's when you start to miss a lot of things. So then we have this thing called a review of systems. So for those of you in med school, it's a review. For those of you not, the review systems, it's basically listed into, it's basically broken down into different abdominal systems or different body systems. So for this patient, we asked them to review the system. So general is going to be just some overall things that don't fit into any specific category. So he said, yeah, I'm having some weakness. And these are yes or no questions you can ask this patient. A lot of the times the review systems is important. So when you ask them, you're opening up a huge, I guess, wormhole for patients to go down, because then, you'll say, do you have shortness of breath? And then they look at you and they'll say, I had shortness of breath when I was exercising yesterday. And it's like, okay, so before you ask review systems question, you always want to tell them, I'm asking you questions that pertain to how you're feeling in this exact moment. I know you may have had experienced some of these symptoms like in the past, or like way in the past, like people will tell you, oh, a month ago, I had constipation. But you want to kind of help them realize that you're asking questions pertinent to now. So HENT, which is like head, ears, nose, and throat, denies any changes in hearing, vision, or taste. Cardio is your cardiovascular symptoms. He denied any palpitations or chest pain. respiratory is your lungs, anything that's associated with that, upper and lower airway. Deny any shortness of breath or cough. So you're slowly getting things off your differential. You know, he's not having any palpitations or chest pain, maybe less cardiac, but, you know, we'll still keep it in mind. Respiratory, denied any shortness of breath or cough. So lower on our differential, but we can still keep it. Abdominal pain, denied any pain, any diarrhea or constipation. Endocrine's a huge one, especially in certain cases when it calls for it. If you're thinking like hypothyroidism, these questions are good. He denied any increased hunger or thirst, no feelings of extreme cold or warm. Renal and GU, he had no blood in the urine, no pain with urination. A lot of times this is a good question to ask because the older population can present very differently if they have UTIs, urinary tract infections, where basically bacteria that's not supposed to be in your urinary tract gets there, and then you get an infection and it manifests in very different ways. You can have altered mental status, different types of pains, and, you know, a simple urine analysis where you take a sample of their urine and are able to analyze it. You're able to kind of treat them with antibiotics and get them feeling a lot better without doing a more prolonged workup. Because a lot of times you don't want to miss the little things and do this whole workup just to realize, oh, we should have asked this one question in the history. MSK, musculoskeletal, it's important to know. So he had no joint pain, no back pain. So then this also is like important because, you know, you may be the first one diagnosing someone with, it's like, yeah, you know, like I have like this bilateral joint pain or I have knee pain. You know, you could be one of the first people who's ever asked them that. Dermatologically, he has no rashes, no itching or bruising. So, you know, he didn't fall. Like, I'll get into that more, but he didn't fall. There's no bruisings or anything like this. And then in terms of psych, you always want to ask, well, at least in the ER when people come in, just in general, it depends on the person, but we always ask any suicidal or homicidal ideations. So now here are the two things. So what are some of those problems this guy has? He had this quote unquote seizure, just having some weakness, you know, and what are some differentials? So basically his wife found him on the ground and then he had a seizure. What kind of questions do you want to ask and what are some differentials? So problems would be like, he passed out, right? Weakness is a problem, what can be causing it? And then differentials are more specifically, what is causing that problem? So what can cause you to pass out, essentially is what I'm asking. So you guys can write in the comments, what are some of the things you're thinking? So, you know, like, was he dehydrated maybe? And then he passed out? You guys can put whatever answers in the comment section. I would not have known what to say as a pre-med. So you just put out what you think. Does he have a history of diabetes? Low blood pressure could definitely cause it. Hypoglycemia. Yeah, and hypoglycemia is a big one to check on some people. Dehydration, eating enough, eating habits. Okay, low oxygen saturation for sure. Okay. So then some of the other questions you would also ask for the problems, like did he hit his head? Was there any bowel or bladder incontinence? How long was he unconscious? And then some of the differentials of what you're thinking. Seizure, stroke, was there a cardiac arrhythmia? Was he dehydrated? Is there something medications would cause it? And then electrolytes. So here's more of his history. I know a lot of you have been asking. So he does have a past medical history of diabetes, hypertension, hyperlipidemia, and gout. A lot of the times people, I'm trying to give you guys a real, like, this is great to go through it like this, but I also want to give you kind of the reality of how it goes when you're actually a resident or a medical student. And you go and you ask this guy, and he may not be able to tell you all this. Oh, he'll be like, oh, you know, I had, someone told me I had high blood pressure and I have some other medical problems. And they stop talking. And then it's your job to, you know, dig a little deeper and remind them of what it could be. You know, I always ask, like, oh, did anyone ever tell you you have a sugar problem? And then they'll be, oh yeah, you know, I do have diabetes. Or like, you know, is your blood pressure ever too high? You know, high cholesterol? And they're like, yeah. And you can kind of get more information to help put you in this context. So, you know, just from seeing this diabetes, hypertension, hyperlipidemia, gout, you know, then we have past surgical history. He had an appendectomy in the 1970s, and then he had a total right knee replacement in 2014. So important, but it doesn't really help you out. Allergies. When you're asking allergies, it's important because you always want to know the reaction. So I split it up into like two categories, like allergies we're worried about and allergies we're not sure what the reaction is. So allergies we're worried about. If someone's like, oh, you know, and they can say the exact name, like, you know, I took a sulfa drug, broke out in hives, wasn't able to breathe, it's called 911. You don't even want to take the risk. some people are like, oh, I'm allergic to penicillin. They're unsure of the reaction. They're like, oh, someone told me years ago I was allergic to penicillin. And then sometimes people are like, oh, I'm allergic to this food. What's your reaction? So that's a huge question you want to ask. If you ever ask anyone allergies, you always want to know the reaction, because it helps you understand like how severe is this allergy and what you need to be careful of. If you're unsure, we generally just stay away from them, because there's other like antibiotics, especially like if someone's like, oh, I'm allergic to penicillin, there's different drugs you can give, so it's not even worth the risk. And then some people will give you like different food allergies, and you're like, okay, well, we don't have, like, we're probably not gonna be serving you seafood, so you document it, but you just don't really worry about it. So social history is also important. Some people don't ask social history questions because it's they feel like they're very personal questions, but they're really important. So like you always want to ask tobacco use, alcohol use, and illicit drug use. So you always want to say tobacco use, because then some people are like, oh, do you smoke cigarettes? And they're like, no, I do not smoke cigarettes. And then if you ask them a different way, they're like, oh no, but I have like 3 cigars every day. I just don't smoke cigarettes. People don't know how to answer some of the questions. So you want to be specific, like any tobacco products, and you can give them examples, like, especially now, oh, do you use a vape pen? Do you use this? And then he's like, yeah, I had a 14-pack year history, but I quit more than 10 years ago. And then alcohol use is another important question you want to ask. I didn't realize this until I was in residency, like 2 months ago, like how little it takes, like, for people to start withdrawing from alcohol. Because a lot of people think like, if someone is using alcohol, it's like, oh, I'm drinking like 15, 20 beers a day. But, even if you drink, some of these people who are more chronic, their receptors in their brain are suppressed due to the alcohol use. And once you admit them to the hospital, they might not realize even that they're missing this alcohol in their system, and that it can cause withdrawal seizures. When you go to examine them, they're like, they start sweating, they're shaking. That's because they don't have the alcohol. So you always want to find out and quantify kind of like how much alcohol they are using. So a lot of times, I'll ask them like, how much do you drink, let's say in a week? And like a lot of people think, oh, I only drink on Fridays, or like, oh, I only drink on Saturday, Sunday. But some people are like, oh, like I drink basically every day. And then you can kind of get more into, oh, like, they're like, oh, I don't know how many I drink. And then you just ask like, how many like beers would you have, or how many, like, what's your drink of choice? And like, how many of those? And like, oh, I have like 4 vodka sodas in a day, and so you're able to know more. And then a lot of times people don't want to ask illicit drug use, because they think it's an offensive or very forward question. But an easy way to do that is before you start social history, be like, we ask all our patients this. I don't want you to take it personally. We just have to go through our checklist to make sure we're not missing anything. Do you happen to use any illicit drugs, such as marijuana, cocaine, anything like that? And then if they, some people are like, no, I definitely don't use that, then you just let it go, but at least you're asking. And then if they're able to offer up that information, then it's just helping you with your history. And another thing with illicit drug use is, if you just phrase it as in like, like this is just personal, this is confidential information between a doctor and his patient. So, like a lot of people are worried, like especially the younger patients that we deal with, like get worried, like, should I say like I use marijuana, or say I do this? And it's important to just emphasize like the doctor-patient relationship and how it's confidential, and nothing they say, unless they're going to hurt someone or hurt themselves, is going to be sent out to other people, and they have the right to privacy. And I think that's a big thing that physicians need to remind their patients, that because some people are embarrassed, and some people just are unsure of like what they're able to say to their doctor. But we see so many patients that a lot of people are embarrassed to tell us things. And I like to remind everyone, like, we've seen everything, and your case is probably not as bad as you think it is. So it's better just to be honest. And I think, just speaking with that tone with your patients, and just reminding them there's no judgments from the physician's standpoint, helps them open up way more, rather than coming off as judgmental. So whatever they say, I know you may have your own reactions to it, but, kind of keep them to yourselves and be like, okay, like, that's fine. If you drink this much or you smoke this much, you don't say, oh, that's so stupid, I can't believe you do that. Just be like, accept them. And then later on, when the time comes, you can counsel them on like maybe cutting back, or, quitting alcohol use. So let's look at his medication. So metformin, he's on sitagliptin, lisinopril, doxycycline, and atorvastatin. If I was a pre-med student, I wouldn't have known any of these medications, but maybe some of your family members take some of these medications. So does anyone know what some of these medications are? If you guys want to write some of them in the chat, like what's metformin for? Maybe not what they do, but what are they for? Like, why would someone be on metformin? So metformin and sitagliptin, they're diabetes drugs, and then lisinopril and doxazosin, they're for high blood pressure, and then atorvastatin, that's for high cholesterol. So those are like the main categories. You don't have to know exactly how they work. That's like a later down the line in med school sort of thing. All right, so then we look at this guy's vitals, and we see, his temperature is normal, 98.9 degrees Fahrenheit. His heart rate is 72 beats per minute. His respiratory rate's 14, and his blood pressure is 112/90. So it's always important to look at the vitals. I can't tell you how many times that we, like, even when you're reading questions, not even just with patients, is looking at the vital signs can lead you, can help guide your differential. If this temperature was like 102.4, you're thinking a whole different thing, or if it's normal, you're able to rule out a lot of things. The next vital sign is heart rate. So normal heart rate is anywhere in between 60 and 100. We often see less than 60 with people who have bradycardia. That just means their heart beats slower than normal, and this could be due to some arrhythmias, some different types of heart block. It could be due to a medication. Well-conditioned athletes, they also have a heart rate under 60. Anything over 100, we consider tachycardic. This could be due to fever. This could be due to pain, irregular heart rates, atrial fibrillation, VTAC, anything like that. And then for the next vital sign, respiratory rate. Respiratory rate is around 12. So this person has a fine respiratory rate, like 12 to 20 is what we're usually looking at. His is 14, so it's fine. You always want to evaluate respiratory rate in context to the patient. So if you look at them and it's 19, but they're really struggling to get those 19 breaths out, you have to be, you should start getting worried, like, because whenever you see a patient, and like even with this patient in the room, you always want to look at airway, breathing, and circulation, your ABCs. So making sure they're able to breathe properly and like they're going to be able to maintain their breaths is very important. And then their blood pressure, 112/90. So normal blood pressure is 170/80. There's a lot of controversy on what normal is for certain patient populations. So from like what our level is going to be is 120/80 right now is good. There's several different guidelines that you can follow. So then you move onto your physical exam. So a lot of this sometimes isn't in a stepwise order that I'm doing, but initially when you start out training, you should start doing it in a stepwise manner. But a lot of these things I'm doing at the same time. Like I'm looking at the vitals, I'm doing the physical exam, I'm asking them questions as you go along, just because it helps you speed up. But as long as you have your set algorithm in your head, you'll be able to deal with it a lot better. So generally, you always want to look at how is the patient, is he in mild distress? But no, this guy was just laying in bed. He's AAO times 3, so alert and oriented times 3. So what are the 3 questions you should ask if someone's just had like a syncopal episode, just had a seizure? And his oxygen saturation, let's say it's 98%. Oxygen saturation is a whole other thing, and it depends on the patient. A lot of the times we want it above 92%. Some people are chronically, some people could be, not everyone has to be at 100%. We actually don't like everyone to be at 100%. There's different medical conditions that actually, 94 is a good, sometimes people are just conditioned to be, and they're able to survive at a certain oxygen level saturation. So it always depends. So yeah, back to the AAO times 3, you always want to ask them, are they oriented to self? So it's simple, don't get tricked with a lot of patients. You'll be like, what's your name? And then they look at their bracelet and they'll tell you their name if they don't know it. So you want to be careful of that. Where are you? And they'll give you can tell when someone knows. They'll be like, I'm at this hospital in this city. And you're like, okay, perfect. But some people are like, oh, hospital. And you're like, but where? And they're like, oh, New Jersey, but you're actually in Florida. And you're like, okay. And then oriented to time. So you always want to ask. I know it's hard because sometimes they may have been sick for a few days and they're like, oh, what day is it? And they're like, oh, I think it's Tuesday, but it's like Wednesday. That's not crazy. But if they're like, oh, it's 1950 and we're in 2020, you can also ask like, oh, who's the president? And then if they say someone like way off, then their sensorium is all altered. Cardiac, you always want to auscultate. There's different spots to auscultate. This guy had regular rate and rhythm. He had no murmurs. We listened to his lung. CTAB is how you often see it. it was cleared auscultation bilaterally, so there's no wheezes or anything like that. We palpated his abdomen. It was NT-ND, so it's non-tender. So when you press in the 4 quadrants, they split up the abdomen into 4 quadrants, and we palpated in each area. It was non-tender and non-distended. Distended is like when you have that bloated feeling, you push down on someone's stomach and it's not going down and it feels kind of hard. These are really important to check just because it leads you down a whole different set of differentials if it's painful when someone presses on their stomach. Bowel sounds positive in all 4 quadrants. So you listen with your stethoscope, and you listen in all 4 areas, and you're able to make sure that their bowels are working, they're not having an obstruction or anything like that. Musculoskeletal testing is very important. So you want to just test their major joints, and it's graded on a system of 1 through 5, and 1 through 5, 4 out of 5, and 3 going downwards is less and less strength. It's strength against gravity. It's like they can't even hold it up. So this guy had 5 out of 5. If you push your arm, and he'll resist it and be able to push forward. Neuro-wise, he was cranial nerves 2 through 12 grossly intact. So your cranial nerves are up here, and they control a lot of your face movements, your shoulders, all that. So you want to just test those, and as you get further into your training, you'll know how to be able to test that. So what test would you order at this point? So you have a guy who said he's had a seizure. You talk to the wife, and yeah, what would we order if we're trying to rule out things? So also, when you're thinking about what test you want to order, think about when you order this test, what is it going to help you rule in or rule out? He does not have yeah, so a head CT, you could definitely get a head CT. So CT scan versus MRI. So CT, we always do it depends. It depends on who, I guess, is making the decision. Some people say, if they didn't hit their head and, he's alert and oriented, he's back to his baseline, there's no real reason to do a head CT. A lot of times you get a non-contrast head CT to evaluate for any signs of bleeding, because a lot of these patients are on blood thinners. So did they fall? Was it questionable? This guy didn't fall, so it may or may not be a CT. Blood tests, which is good for vitamin deficiencies, that's huge. So what kind of blood tests do you guys know about? Blood glucose is huge. Electrolyte panel, echocardiogram is good. EKG to rule out heart conditions, very good. CBC, urine test, awesome. So yeah, that's kind of what I would order. So an EKG initially, because you want to see, were there any heart arrhythmias? All right, does this guy have a heart attack? Did this guy have, there's so many different arrhythmias that can cause you to pass out. Was his heart beating too fast or too slow? A complete blood count. That's going to be your hemoglobin and hematocrit and your white count. So your white count is one of those numbers that tells you if you're having an infection. It can be elevated for other reasons, but for the broad sense, it's for infections. Then we can see the blood count to see, does he have enough red blood cells? Usually the hemoglobin and hematocrit that you can see right here, these are the numbers we care about. In most patients, it's like 13 or 14, but sometimes you'll see, oh, it's randomly 9. So they're not getting enough oxygen, and that could be one of the reasons that they passed out. Complete metabolic profile is also important, or BMP, so basic metabolic profile. So the major difference between these two, and it's important to know the difference, and if you need to order it, because it costs different money, it costs different amounts. And this is not a thing you guys need to think about until later, but just kind of like, does this patient need to be subjected to this test or that test? So basic metabolic profile includes your sodium, your potassium, your chloride, your bicarbonate, your BUN, your creatinine, and glucose. So it's important because hyponatremia, low sodium, can cause you to pass out. Potassium levels low can cause you to pass out. And like people have been saying, the glucose check, because glucose is fine, but that's one of the first things you could check on anyone, because it's so easy. You literally just prick the skin, have a scanner, anyone can do it in the hospital. So you just check and make sure. So his blood sugar was fine. And then you always want to check the folate, B12, mag, phos. There's just different electrolytes and different things that if they're chronically, like chronic alcoholics, we always check a folate B12 just to make sure they're not malnourished. Mag and phos, folate B12, they can give you a good sense on what their nutritional status is. If their electrolytes are all out of whack, this person may be uremic, their kidneys may not be functioning properly, they may not be eating enough. Hemoglobin A1C Does anyone know what a hemoglobin A1C does or tells? So BUN is blood urea nitrogen. It's a marker to see how well the kidneys are functioning and able to filter everything out. High potassium could also cause trouble, yes. Anything high or low, hyper or hypo anything. It's never good to be hyper or hypo anything. So hemoglobin A1C is going to be a marker of blood sugar over a course of 3 months. So obviously we get a finger stick blood glucose that can tell you in that time, in that moment, what the blood sugar is. But hemoglobin A1C, it will tell you over the course of 3 months how well is your sugar controlled. To be considered diabetic, your number is 6.5 or above. So as you keep going up 6, 7, 8, 9, 10, that makes you a worse and worse diabetic or poorly controlled diabetic, that your sugars aren't controlled and can lead to a lot of neuropathies and different problems like that, which could lead to syncope. So it's important to check. Then you get a TSH panel to evaluate for hyper or hypothyroidism. They can always, TSH is one of those things I get on a lot of patients just because if no one's ever diagnosed with that, like hyper and hyperthyroidism can really throw you off, can change your mentation, can affect a lot of things. Ultrasound carotids, so I get ultrasound carotids on every syncopal patient, or most syncopal patients, I would say. So what that is, they basically take an ultrasound probe and will go against your carotid arteries on both sides. And if the carotid artery is thickened with arterial plaques, you're not getting enough blood flow to the brain, and that can cause syncope. And that's an easy way, it's non-invasive, relatively cheap way to evaluate the carotid arteries. Also, 2D echo is another ultrasound. So what a 2D echo does, it's 2D echocardiogram. And what it does is you basically take the ultrasound probe and you put it right to the chest, and then you take different pictures of the heart, and they're able to see it in live, how the heart is functioning, because a lot of the people, some of these people, you have to realize that are not going to get routine medical care. They're coming in for the first time at 60, at 70, and you're dealing with problems that have been building up. So maybe you check the 2D echo, you see their heart function, and a normal ejection fraction of how much blood is able to get to the rest of the body is about 60 to 65%. Some of these people come in and it's only 30% or 20%, so they're not getting enough blood flow to the body. And getting these tests can help you differentiate the different causes of syncope. And then chest x-ray can always let you know if there's a possible pneumonia that's causing you to be sick and dehydrated and ultimately pass out. Is there a mass we're missing? So does anyone check his medication list and like how long he's been on them? Because we always get involved in testing and all this stuff, but we should look back at his medication list and had any of them been solved, were any of these affecting him. So this is like a patient we saw. We did all this workup, and then I didn't really look at I looked at his medication list and I'm like, okay, that's fine, like he's on these. But this doxazosin is notorious. It's an alpha-1 blocker. So you have alpha cells that are in your body, which when activated will cause constriction of your arteries. It's causing, I'm speaking in a very general sense, causing high blood pressure. So the hope of this medication is you're blocking the alpha-1 receptor, so it'll do the opposite. Rather than clamp down, it'll open up and let essentially decrease the blood pressure. However, one of the major side effects of this medication is orthostatic hypotension, a positional change in blood pressure. So this patient had just been put on doxazosin the day before and had taken it at night. So when you get up from bed, basically, most of us are young and healthy. So you get up and your arteries and your veins really clamp, and they're able to get blood to your brain, and you're fine. You can wake up and start your day. The older you go, the looser your valves get, arteries and veins, and doxazosin alpha-1 blockers are notorious for causing orthostatic hypotension. So when you go from laying down to sitting right up, all the blood in your brain and the upper part of your body drops down. So you're not getting as much circulation, you're not getting enough oxygen, and it causes you to pass out. So that's exactly what happened to this patient. He was on this medication, he passed out. His wife was in like a vulnerable situation, saw that he was getting diaphoretic, which is like he was sweating. He didn't know what was going on, was having blurry vision because of the decreased oxygen, and they ended up passing out. So he had just been started on this medication. So a lot of the times, another good history question that you can ask rather than having to order all of that, it's like, when did you start each medication? A lot of times that if a patient sticks to a certain hospital system, they are able to, you're able to look at different providers that have different providers who have prescribed medications, and you can see when the last time they filled them was. So, how we checked on, had we checked on this guy, we would have saw like, oh, he just filled it 2 days ago, and this was his first dose taking it. So there's a higher index of suspicion when you have when you see someone's medication list have that. So then this is just like a general overview. This is not meant to be like very in-depth. So transient loss of consciousness in the hospital. This is all from Up to Date, which is a really good resource. You may, like in college, your college probably has access to this, but if you're looking for anything medical related with a good summary of all the concise information, Up to Date is like a great article. So they basically break it down into trauma related, which could be a concussion or any sort of trauma, car accident, anything like that. Non-trauma related, which is syncope, seizures, intoxications, or metabolic. So syncope is something we saw, this guy had orthostatic hypotension. Seizures, what if it was actually a real seizure, provoked seizure? Intoxications, if you're, that's not only alcohol, it could be different drug intoxications, different electrolytes. Some people take herbal supplements and it ends up being too, their levels get too hyper or hypo. Any metabolic derangements, that's why we check a TSH and make sure all the electrolytes are in check. And then not true loss of consciousness, that's another big thing that you want to make sure they actually did lose consciousness. A lot of the times people will be like, oh, I felt very lightheaded. And then you further, this question thing I keep going back to is really important. You ask them further and further, and they're like, okay, well, I didn't really pass out. I just got really lightheaded. Then I sat down and I was fine. So this could be like pseudo syncope, and they could have just been anxious, could have been an anxiety attack. But you always want to rule out, you don't want to, like this case, for example, we wouldn't have just stopped at like, oh yeah, it's probably because of his medications. Like after a while, we did be like, oh, it's probably because of medication. But there's further workup you have to do to ensure that this person is actually having, this orthostatic hypotension. So one of the things that we do for orthostatic hypotension, we do 2 blood pressure readings. We do one with them laying down, or I guess 3, one laying down, one sitting up beside like on a chair, and then one standing up. And we want to see that when they stand up, is there a drop in our blood pressure? So you have your systolic number on top, which is 120, and your diastolic number on the bottom, which is 80. So we want to see, is there a drop of blood pressure in the systolic where it's 120? Is it greater? Does it drop down from 120 to, let's say, 99? So it's greater than 20. That can be diagnostic of orthostatic hypotension, or the diastolic number drops greater than 10. So if it went from like 97 to 87. So it's an easy way, non-invasive. You're just taking blood pressure medications. You always want to do it with someone, so you have someone to catch the patient, because a lot of times they stand up and then they will immediately start to feel like they're going to pass out. So just being able to catch them. So you don't want to just do this randomly without like a bed or anything by. And we always warn the patients when we're doing this, be like, hey, like you just had this event, so when we stand you up, this might happen. And then getting the feedback from the patient while you're doing this is important, because you don't want to just like stand them up and you're just silent the whole time. But if you walk them through that and explain like, hey, we're going to sit you up, you might start to feel lightheaded again like you did, and what made you call in or made you come into the hospital. So you want to just be sure that you're talking them through the whole thing. And I think that builds great rapport with your patients. They trust you way more. And it's just better for both you and the patient, because you're able to communicate what's going on, and they're able to get a better understanding and feel like, for this guy, we just basically took him off his medication. But some people, if you do simple things like this that go a long way, they think, oh, they didn't really do anything. But if you explain like things that you've ruled out and show them like, hey, we did this EKG, it was normal, we don't have any reason to believe it's this, and then you give them the proper follow-up, a lot of them are very satisfied with the care you get. And these are, I just put in some of these, just kind of the initial assessment, which we kind of already talked about. And these are just some of the different cardiovascular causes of syncope. There's so many, as you can read. If you just look up like syncope due to cardiac arrhythmias, there's so many that you can learn about, and they're really cool if you're interested in cardiology and all those. Yeah, so that's basically it. And then I left like 15 minutes to answer some questions and just give some general advice. So if you guys want to ask some questions in the chat, I like have access to it, and then like maybe you guys can pick out some ones that you want addressed.
Thank you so much for your presentation, Dr. Patel. We want to deeply apologize for the beginning. We were having technical difficulties and became nervous, and unfortunately, we're nervous laughers. So we didn't mean to disrespect you or take away from the presentation at all. Also, we're just college students, let alone human, like the rest of you participants. We're not robots, and we're just fellow pre-meds trying to help out our peers. Regardless, we love the presentation and hope you guys appreciated it as well. Again, thank you so much, Dr. Patel. It was an awesome presentation.
Yeah, of course.
Everyone, please feel free to stick around and ask Dr. Patel any additional questions you may have. We can comment the questions on the chat box if you want.
Yeah. Yeah, so let's do that. Yeah, so I guess we'll go with whatever questions we have in the chat.
We're sending them right now.
Oh, sorry. Okay. Yes, I see one now. I really like Nova's DO school. I just love the people more so than anything. Like a lot of my classmates are very supportive. I feel like the structure of all the classes is very good, and just overall, like just the location and the opportunities it had, the rotations were really good. So I decided DO. Initially, I didn't know too much before going in, but I'd been treated by DOs in the past before. So I just felt that DO and MD are very similar in what they are. DO just has some extra training in musculoskeletal medicine. A lot of people are wondering, like, oh, does it hinder you to go either way? DO and MD positions and training, you can do any specialty. I have friends this year who matched into orthopedic surgery, they matched into vascular surgery, ophthalmology, family medicine, emergency medicine. Every specialty you can think of, my friends who went to DO school with me have matched into. So it doesn't hold you back. Even with MD or DO, anything that's going to hold you back from getting a specialty you want is more so on you. That you didn't put in like the work and the effort, but just from what I've seen, like people match into any specialty that they want. How has COVID-19 changed your practice? So I'm only 2 months in. I didn't really work in the height of like when everything was going on, at least in New Jersey. It's still, I guess how it's changed is we're taking way more precautions, I feel like, than when I was a fourth year rotating, with the masks, hands washing, everything's a lot cleaner. We're ordering COVID tests, and that's like a huge thing. That's always on everyone's differential now when anyone comes in the shortness of breath. So I feel like it's changed a lot of the differentials, and kind of like if someone comes in with these symptoms, we're always like, let's check if it's COVID, and then we'll worry about everything else. So it's kind of like a funnier thing. What do you recommend to stand out applying to a BSMD program? I think BSMD programs are looking for experience. Obviously, like they want to see interest because they're offering you a good deal. Like they're saying, like they meet you in high school and they're like, we're gonna let you come to med school as a high schooler, basically. Like we'll take you as we know you now, and like they're placing a big bet on you. So I feel like just showing how that you're a professional, that you're able to handle yourself at the interview, showing that you are interested in medicine, that you've had time to think about it, and like you've thought about it for a long time, and you're not just doing it on a whim, is really important because they want to pick people like that. How are you able to keep up fitness with struggles in medical school and residency? So I was just talking to the girls before we started. Like fitness is a huge part of my life. I work out almost every day. I think you just have to make time for it with anything that you pursue. Like your life can't be on hold for these things because you're going to be doing this for the rest of your life. Like medicine doesn't get easier. And I try to tell a lot of people that. Like people are like, oh, wait till residency to start working out. And I'm like, you don't get more time. Sorry, you don't get more time in residency. Like medical school is hard enough. So I think planning out your time is huge. And you do have to give up some stuff. It's like as soon as I get back at 5 o'clock after like 5 hours of lab, it's like, no, I don't want to go to the gym, but it's something you do, and you just have to stay disciplined about it. And if you don't want to set goals that are unrealistic when it comes to working out and like staying active in medical school, because it's hard. It's like you can't say, oh, I'm gonna work out 7 days a week and you've never worked out before. Like, you have to be like, I'm gonna commit to 3 days. Like I know both weekend days I don't have any class. I can definitely go Saturday, Sunday, and I'll pick one day when I don't have lab. I'll just go, So I think it's really important. I think people need to, the sooner in your life that you get an exercise or activity regimen in place, the more successful you're going to be long term, because of you're just able to function better. You're happier. You have that endorphin rush. You have a release. Like all day, your mind is stimulated. Like it doesn't get easier, guys. Like you're studying the high school stuff. Like I did all the AP classes, like biochem, organic. It doesn't get easier. Like your mind is focused on that. So like even if you take 30 minutes and you're like, you know what, I'm not going to study. I'm going to go play basketball. I'm going to go play tennis. You're just going to be a happier person, and just like you're going to be able to survive longer in this field. Like a lot of the people I see who like all they do is read and just do medicine, they're not happy people. Like some people are, like they enjoy, like their whole life is this, but like that's not me. And like I've noticed like my friends and colleagues who, you know, like even my attendings are way older than me, who are like, no, I still play pickleball, I'll go play tennis, I'll work out, are so much happier. You know, you don't have to study like 12 hours a day to be successful. Like if you're just efficient with your time and like, you know, you're like, I'm going to put my phone away, I'm going to study today for like an hour without looking at my phone. That's like a thing I started doing in undergrad. It helps you light years, because a lot of people will be like, oh, I studied for 12 hours and show off, but it was like you're on your phone half the time, or like you're getting distracted. So I think quantity over quality would really help you out, or quality over quantity, with studying and fitting in fitness and things like that in your life. Any tips for writing a personal statement? So personal statement is like what it is. You want to say it's personal. So you want to showcase things that maybe you want the residency, you want the medical school, you want the college to know about you. And I think people get afraid and aren't personal enough. I think people always try to paint themselves out to be this person that they're not. They show up to the interview, and programs can see that right away. They're like, you know, this doesn't match who this person is. Like my personal statement for residency was like literally how I'm talking to you guys. I was like, I love working out. I love preventative health. This is why I want to go into family medicine. And then when they, you know, when I came to interview, they're like, you know, this personal statement really matches who you are. And if you have things in your resume that are glaring, like you know, if you failed a class or anything like that, and you had a major life event, that's an opportunity to talk about it. You know, you're able to tell people like, hey, listen, like this happened to my mom or dad or my uncle, and you know, or I was moving and I had this life scenario that happened to me. I got sick. You know, you can make it a little part of that, but don't make it the whole focus of your paper. I think some people misconstrue that and make it the whole focus, but you want to just be honest. You want to put time into it. You don't want to just be like, oh, it's due on Saturday, so I'll just start it Friday night and just submit whatever. You want to go through multiple revision processes, show it to people in and out of medicine, and then like, especially the people outside of medicine, they'll be like, dude, this doesn't sound like you, or like, hey, well, why don't you talk about this? Like, you know, you love doing X, Y, and Z. Like, you didn't mention anything about that. Because it's really personal, and you want to showcase why you like medicine. Like, because everyone's going to say, oh, I like helping people, I like this. But if you're like, if you genuinely like, yeah, I really like, I shadowed a few surgeons, I really like that. I think this is where I fit in medicine. This is how my interests could fit in, and just be honest. I think that goes a long way. Why did I choose family medicine? Just like I said in the beginning, the preventative health aspect, and just being able to help others, and getting the time to talk to people as an outpatient basis, especially that you can do sports medicine, which is a huge focus of mine. And being able, the opportunity to do that was very huge on that. And I just like the people in family medicine. They're very, some other specialties you'll see are very research oriented and cutthroat, very academic. And some people enjoy that and thrive on that, but I thought family medicine was a better fit for me. What extracurriculars did you participate in? What did I do? So in high school, I volunteered at a hospital. So I was like a front desk boy person, and I would like when people's families come in, I'd like check them in and then like give them passes. And then I was like, oh, you know, I like want to do medicine. So they were like, all right, like why don't you go to the ED? So I'd help like stock the rooms, and if there was cool cases, I would see patients. Basketball is a huge part of my life. I played basketball growing up forever. I'm trying to think what else I did in high school. I was really involved in student government. I was a vice president of our high school my senior year. Yeah, different things like that. A big thing on extracurriculars, do things that you enjoy, and don't do things that you think you have to do to impress people. Because I think when you do that, you end up just being like, oh, I have to go do this. But nothing I did, even in undergrad or med school, was like, oh, I have to do this. It's like, oh no, I'm like loving this. I get to do this. So I think a big thing is if you do extracurriculars that you enjoy and you put a lot of time into, it's going to show. But if you do like 20 different things and you've only spent like 5 minutes or like 2 days a week or 2 days a month doing it, they're going to be like, oh, well, you know, what did you like about volunteering at this place? They're like, and you have nothing to say. But the person who it may not be like a medicine related thing, but you spend like 100 hours a month or something crazy, and you're like, I really love this organization. They're doing X, Y, and Z. I helped this. That really comes out when you have your interview, when you're writing about it in general. What do you dislike about being a doctor? I mean, like, no career is perfect. There's always different things about this. So for, I guess, things that are, or you should know up front, is like, it's a time commitment. Like, you do miss a lot of things. You don't see, like, I see my family and friends a lot, I feel like, compared to some other people, but you're definitely missing out on stuff where it's like, you have an exam, like even in pre-med, like, I have this exam, so I can't come to this. I was in school in Florida, my whole family's in New Jersey. I'd be like, I literally can't fly up there, like having an anatomy exam tomorrow. Like, so you miss some life events, and like the hours you work are crazy. Like in residency right now, some days I get in at 6 a.m., I leave at like 7 p.m., and you're working multiple days in a row before a day off. But if you enjoy it, like, these are like what I like it. So I don't really care. Like, I'm there for like maybe 13 hours a day sometimes, but if you enjoy it, none of these things are going to deter you from like choosing medicine. What research have you done? So I don't like research. I never have done research. I like case presentations. I've done several case studies. That's like when you have a patient come in and it's like a rare case or a different presentation, you write them up and kind of increase whoever's reading it being like increasing their differential list, and they'll be like, oh, like when I have a patient come in like this is what I should think about. And you're presenting rare cases, and I've done like posters for that. So I guess I like to do case presentations more than research. Research is someone else. Like, you can ask them. I'm not going to act like I know how to do research and get involved. But if that's something you're interested in or passionate about, you should do it. If you're one of those people who's doing research just to do research and you genuinely dislike it like me, don't worry about it. Like, you don't have to. Everyone's like, oh, you always see people who are pre-med, I have this many publications and all this stuff. You can do journals, you can write articles, you can do different things. Like, it doesn't have to be bench work research that's so hard to get, because I know it's so hard to get, like, especially if you don't go to like a huge academic place with a lot of opportunities. Like, I've been there, like, so don't feel like you're out of the running because you don't have any research projects. But always talk to people, because you never know who's working on what. But if you express an interest, they're more likely to help you out. So what do med schools think about introverts? So med schools, they accept a wide variety of people. There's people who are extroverted like me, like love to just like be out there talking to people. And then there's people in our class who are very introverted. So I think they're looking for a good mix. I think if you are yourself, that's what's most important. I don't think they're looking for X amount of personality types or anything like that. They just want to see, are you a genuinely good person who's going to work hard here and represent their school well, really? Tips for letters of recommendation during COVID. I mean, it's tough. I feel so bad for like everyone who's applying right now, because it's like we're trying to give everyone good advice, but we've never done it ourselves. So we're just speculating, really. I guess one of the things is keep in touch with the people that you want letters of recommendation from, every like 3 weeks. So you don't want to email them every day. Like, hey, I need a letter. But like every 2 weeks or so, like, hey, doctor, whatever, or, hey, Mr. Whatever. Just got like this grade back, really doing awesome in anatomy, really liking it, excited for med school, whatever. Or, hey, like I just went to this web shatterers event and there's this awesome guy, he's Dr. Patel, he was so cool, and I learned about this, or just anything that you want to put on there. And I think if you just keep in touch, because a lot of people, they'll be like, oh yeah, I'll write you a letter. And then you don't hear from them for 6 months and you're like, oh, this person probably hates me, like they don't want to talk about it to me. But it's because like people don't follow up. And I think that's a thing that people need to learn. Like, it's a balance of not being too much. It's like, every 3 weeks, or like with a mentor, like every month being like, hey, I'm free this days, like if you want to call me, we can catch up, and like I can, kind of update you on my life. And if you update them more regular, like, I know COVID's causing this, but I'm proactive and I actually signed up for this online thing, or I'm still making time to do X, Y, and Z. When they sit down to write your letter, they have more things to talk about. How to deal with major interview anxiety. That's tough. I mean, interview anxiety is real. Like, even my first few residency interview, first few residency interviews were hard, because you're just nervous, because now it's like a different level. Like, you're speaking to physicians, you're speaking to residents, and like people who are judging you so hard. So I think it's just focus on being yourself. And if someplace gives you that much anxiety being there, and like how they are, like obviously you're gonna have anxiety going into it, but like once that you talk to them, within like the first 30 seconds, there should just be like, try to just make it a conversation. And if they're very stern and like making you feel uncomfortable, maybe that's not the place you want to be. Because a lot of the places, some place I interviewed for medical school or for residency, I just felt so uncomfortable there. And like some of the people I interacted with, and I was like, this is not the place for me. And I'm happy that I found that out now through the interview, and like this kind of self-reflection, like, wow, I was really anxious during there. Like the place like I matched at for family medicine residency, I was so excited to be there. The people were so easy to talk to. And I think that helps you gauge like, you know, where you want to be and what school belongs to you. Do medical schools value multilingualism? I think they do. I think it adds to your character. It adds to what you're able to bring to the table. So anything that's, you know, different that people aren't doing and that makes you unique is gonna be valued by med school. And then I see this other question: how do you handle doubts when it comes to being a doctor getting into med school? That's like what I was telling them before we started, what I wanted to address. Like, I should be the poster child for you do not have to be smart to be in medical school. If you are a genuinely good person, if you like medicine, if like coming to this kind of stuff, like hearing like some resident talk about medicine and cases, if that excites you and you're like a high schooler or anything like that, this is like the specialty this is like the field for you. That's all you need. Like, you do not have to be this extraordinarily smart person. Like, you do not have to be pulling A's every single day, like top of your class, crushing it every single second. Like, medical school is filled with a lot of those people. But what I realized when I went to medical school, there are so many people like me who are just like genuinely hardworking people who like medicine and just want to like, you know, are pushing themselves. Like, you know, like some people would just, that I went to med school with, would read stuff once and be like, all right, I'm ready for the test. I'm reading stuff like 10 times. I've gone through PowerPoints like 20 times before exams. Like, it takes me a little longer, but because I genuinely like it, I work hard, you're able to do it. And like I was telling the girls before we started, like, I was so intimidated by med school because I thought the first day they would be like, go see this patient in the ER. They're having a heart attack. Go fix them. And it's not like that. It's literally like the first day they start with, we're doing biochem, anatomy, and physiology. The first class is like, okay, so sodium goes into the cell and potassium goes out. And then like anatomy is like, so the shoulder is a bone, which is connected to your arm like this. And like, you know, biochem is like, so can someone name all 20 amino acids? Like, that's how the classes start. It's not, they don't throw you into medications. You don't even start doing that stuff until second year. The pace is obviously a lot faster. The volume is more, but they only ask you the tests. Like, obviously the tests are hard, but I guess looking back at that time I was freaking out, but looking back, it's not like, if they give you PowerPoints, right? If they give you 10 PowerPoint packets, that's all they're going to ask you. I know that's a lot, but they're not going to ask you stuff that wasn't, and you know, there's obviously exceptions to this, but they prepare you for the exams. Like, they want you to do well. It's not like medical school or undergrad where you're competing for this crazy spot, like crazy, only like X amount of spots, or however many percentage get into medical school. Like, if they accept you into medical school, they want you there. Like, you are deserving. Like, if you get in, like, they want you there and they want you to stay in there. There's no benefit to them failing you out and like being super cutthroat and kicking you out. Like, it's not in their best interest to do that. Like, there's so many resources, so many people. Like, the second years, the third years, the fourth years all had tutoring sessions for us as a first year. Like, there's so many free resources online, guys. Like, so much free stuff where you don't spend a dime to get extra tutoring. There's so many different videos that explain everything. If you're interested in medicine, that's all it takes. Like, and just hard work. Like, some people, I know lazy people who have made it through med school who just show up to the exams and kill it, and that's great for them. It's what works. But like, you don't feel like, I really want you guys to be like, if it's for you, like, just do it. Like, you don't have to do it like how I did it, like straight through. Like, I'm 25 and I'm finished. Like, I know people who started med school at 30, 35, 28, who were engineers before, who worked at restaurants before, like who was a bartender before. Like, you can do whatever you want. Like, it's not a rush. Like, medicine's going to be here. Like, you have the rest of your life to be a doctor. And like, I don't want you guys to pick a different specialty and being like, I'm probably not smart enough to be a doctor, so I'm just going to pick this, or, I'd rather do this because it's quicker. But it's like, when you get to that point, you're going to be like, damn, had I just went to med school, I would have been a doctor by now. Or, you don't want those regrets. Like, everyone's capable. Like, if you showed up to this and are showing interest that you're coming to this, these kind of events, like, you can do it. So like, just like, be involved, just be like attentive, like, stay focused on your goals. Like, if this is like what you want to do, and like there's no other career for you, like, just do it. Like, no matter how many times it takes. Like, we have people in our med school who tried 3 or 4 or 5 times to get into medical school, and like, imagine how much it must have sucked for that person the first time, the second time they didn't get into medical school, and they still did it. And now there's some of my friends who've graduated with me and are orthopedic surgeons now, who are like ophthalmologists. And it's like, like, imagine if they were, after the first time, they were just like, oh, I'm just like not good enough. But if you really push yourself, this career is for you. Like, you're gonna do it. Like, you really don't have to be that smart to be in this field. You just have to be extremely hardworking and focused on it, and you can do it. It's obviously, you have to have some level of intelligence, or you wouldn't be making it in pre-med. But like, don't get discouraged. Like, I got like my first like orgo grade, I remember, was like, I think I got an E. I did so bad on it. I didn't even read the textbook. I didn't know you had to read the textbook for orgo. Like, I was like, I'm gonna get kicked out of this program. Like, life sucks. Like, but like, had I just let that like defeat me, like, I wouldn't be here. Like, not everyone's perfect. And if you really like these people who look like they have it together, who, who are always like, oh, I write out all this stuff on my whiteboard and I get A's on everything. Like, they're going through stuff too. So like, don't feel like, if you're just like really trying to break through, if you're just struggling to get like the first problem done on the worksheet that you get, like, don't worry about it. Just like, I think, what if I would have like been in high school or an undergrad myself, like, just focus on your own stuff. Like, so many people are so insecure and will try to push you away from doing medicine and being like, like, oh, well, I'm doing this. You don't have research, you're probably not going to get in. Like, so many people are ready to tell you that, but there's very few people like me who are going to be like very upfront and honest and be like, you can do whatever you want. Like, don't let these people influence you. Like, you guys are like more than enough, and like, you're going to do it if you want. Like, even if it's not like you're not a doctor by 25, like, you'll be up by 30, you'll be up by 28. Like, there's no rush. Like, once you get here, it's a long road. Like, once you get into medical school, that's like, it starts, and like, you're going to make it through. Like, just getting into medical school, you're going to make it through more often than not. So yeah, that was kind of a rant, but just like, so you guys know, like, I don't want anyone to feel like, because I always felt like that. I always felt like I would go to these events, like MCAT class and like all this kind of stuff, and be like, wow, these kids, like, their parents are doctors, they're like just gonna be fine, and like, they have their lives together. So don't feel like that. Like, you don't have to be extraordinary to like be in this field. Like, as long as you're hardworking and a good person, like, that's gonna go such a long way. And like, even in residency and all this stuff. That was a lot.
Again, thank you so much, Dr. Patel. We learned so much from you. Everyone loved you in the comments too. Everyone make sure to check him out on his socials. His Instagram is Vinny Patel. Additionally, thank you all for attending. The link to the Google form has been posted in the comments as well as in our Instagram bio. So please fill it out within the next 30 minutes for us to receive verification of your attendance. And also, I just want to say thank you to everyone who's been patient and in the comments and is saying, please stop asking, let him finish. We really respect that. So thank you so much to everyone. We hope to see you all at our next session tomorrow.
Thanks,
Thank
guys.
you again. Thank you, Dr. Patel.
Yeah, you guys, awesome.